Hi, everyone. My name is Emily Billow. I'm the Older Adult Program Manager here at the Seattle Public Library. We are going to be recording this session today, so if you do not want to be on our recording, it'll go on our YouTube channel for patrons to access whenever. If you don't want to be on it, just make sure to not talk until the end. But if not, they don't know anything else about you. We're just recording this front part. Um, and with that, I just want to introduce Jean, our presenter today. This is a great comprehensive program on Medicare, and we are excited to have her here at the Central Library today. So thank you very much for coming, Jean.
Okay, real quickly, everybody who's online, welcome. I'm Jean Cormier. I'm going to be your Medicare guide as well as people in this room. Um, Now that you saw me, I'm going to turn off the camera because that's going to be distracting otherwise. Yeah, so thank you so much for taking the time to attend today. We really appreciate it. You're here for a reason. You want to know about Medicare because it just seems so straightforward, right? So, a little bit about me as a speaker. I've been working in the Medicare marketplace for 15 years, but prior to that, I was in kind of the regular health insurance for 5 years. So, you would think, oh, 5 years of health insurance industry, going to Medicare, you know what's going on, right? First time someone explained Medicare to me, I'm like, what the heck? Can you go over that again? That doesn't make any sense at all. So if that's kind of where you're at, like I'm an intelligent person, but how the heck does this work? Welcome to the club. That's where a lot of people start. So I'm here to be your guide. So I do work in the insurance marketplace, but I'm not here to sell you anything today because that's the last thing you need is someone to tell you about this really great product that you have to get. You want to understand how this works. And usually our two pieces of information are either the insurance companies and the insurance agents trying to sell us something or the government, which is just too much information, right? It's very technical, and the Medicare and You handbook is 160 pages long. So I'm going to try to thread that needle and give you some really usable information today. And I should share, this is a new computer. Oh, okay, it's not jinxing me. So we're going to cover a lot today. So kind of to set the stage, what we're going to cover, we're going to talk about Medicare Part A and B, when and how to enroll in that, what it covers, how it works, and then we're going to talk about Medicare supplement plans, also known as Medigap plans, Part D drug plans, Medicare Advantage plans. How do you make an informed choice, right? There's so many choices. What's the best option? There's no best option. There's a lot of great choices. It's really about preferences and what's going to work best for you, what you're going to feel comfortable with. And along the way, we'll answer questions or I'll answer questions. I'll take pauses after each section. My request is ask questions about what I just covered, not about what I'm going to cover in the future. So we'll get to everything in time permitting. I'll take additional questions at the end. So the first thing I want to start with, actually, before I don't think I have a slide for this, but the first thing I want to do is I want to reassure everybody Medicare works. A lot of people are facing down Medicare going, am I going to be okay? Am I going to be able to get medical care? And the answer is absolutely yes. Medicare was established in 1965. It is a government health insurance program. And our current modern day health insurance policies, including the one you have here at Seattle Public Library or whatever employer you work for, those medical benefits are based on Medicare benefits. So it is comprehensive health insurance, but it's a little bit complicated. So we're going to dive into the details, but I want to reassure everybody you're going to be fine. You're going to get the health care you need. But the first thing I want to focus in on is the timeline, because sometimes people really miss this. I usually say for most of us, we don't need to start thinking about Medicare until a year or two before we're turning 65. And 65 is a very important number. Some people will qualify before the age of 65, but for the rest of us, this is kind of the timeline you should think about. 1 to 2 years prior to turning 65, start to educate yourself in general what Medicare is about, but you don't need to get into details and study plans in depth. Just have a general sense of how does this work. The next really timeline is 4 to 6 months before you turn 65. And what you're going to do at that time is decide what do I need to do? Do I need to enroll in Medicare right now? Can I wait on enrolling? So 4 to 6 months before you're going to turn 65, you need to start looking into, do I need to enroll now? If so, how do I do it? Or if not, when do I need to do it? And we'll talk about that. Then 3 months prior, this is really important, 3 months prior to when you want your coverage to start, That's when you're going to put through your applications. And I'm specifically talking about the government coverage, the Medicare Part A and B. You can apply for the coverage up to 3 months before you need it to start. And it takes the government a while to process the request. And unfortunately, those wait times are taking longer due to some changes going on at the federal level. So 3 months prior to when you need coverage to start, you need to apply. Now, that being said, we had someone who came into the office the other day and said, I need coverage to start on June 1st. I'm like, okay, let's get the paperwork in and see what we can do. But give yourself that lead time. And then once you've gotten your A and B application in, that's when you go and talk to the insurance companies or the brokers about what additional coverage should I get. A lot of times people want to start with us. I got to figure out what I'm going to get. It's like start by getting your Medicare A and B in place first, figuring out when you need to get it and get that going. All right. So what I do want to cover first is Medicare Part A and B, known as Original Medicare, also known as Traditional Medicare, but this is the government health insurance program. It has two parts, which is a little weird. We're used to insurance policy being just one big policy. Part A is designed to help with the cost of inpatient care, a hospital stay, going into a skilled nursing facility for intensive rehab, those type of things. The government's going to help you with the cost of that type of care with the Part A policy. And then your Part B policy is designed to help with the cost of all of your outpatient care. So this is going to be your doctor's appointments, your lab tests, and so forth. So to give you kind of a sense, I redesigned my deck and I realized I have these slides for you I should show you. But here's your inpatient. So inpatient hospital, inpatient mental health care, skilled nursing facility care, hospice care, home health care. That is all things the government is going to help us with financially if we need them. That's what your Medicare Part A takes care of. Here's your Medicare Part B, and this is not the whole list, but these are the things that people most commonly ask about. So MRIs, CAT scans, doctor's appointments, physical therapy, basic chiropractic care is actually covered by that. Drugs administered by the doctor, things like chemotherapy, infusion therapy. These are all Part B benefits. Medically necessary eye care, cataract surgery, glaucoma, macular degeneration. So these are all benefits that you're going to have when you enroll in Medicare Part B. And there's more. A couple notable things that are not covered by Medicare A and B. Most of them aren't covered by your employer health insurance plan either, but there's a few surprises. The first one I think we know about, prescription drugs, the ones we're taking at home. The government does not directly help you with the cost of those. We'll talk about adding coverage to get prescription drug coverage. Most dental care is not covered by Medicare. You'll notice there is a dental benefit under Medicare, but it is really more about oral cancer or traumatic facial injury. It is not the kind of dental care we're thinking about. Hearing aids aren't covered by Medicare. Routine vision like eyeglasses and a routine eye exam are not covered by Medicare. And most alternative care, naturopaths, acupuncture are not covered by Medicare. But hopefully, maybe I should start with what's not covered and then talk about what is. But other than that, we're talking about comprehensive health insurance, what you'd expect to be getting out of a health insurance policy. I'm going to finish the benefits and then we'll take questions. So what does it cost to go on Medicare? Strictly the government policy. And I can't stress enough, when I say Medicare Part A and B, that is an actual policy with an insurance card. It says Medicare A and B. For Part A, for the inpatient portion of the government coverage, for most people, there is no premium to have Medicare Part A. And then the government's going to pick up the majority of your inpatient care, but you do have to pay something. So for a hospital stay, your share of the bill is going to be $1,676. And that's going to cover you for up to 60 days of continuous care. So if I'm in there one day, it's $1,676. I'm in there 3 days, it's still just $1,676 for that 3-day stay. I'm in there up to 60 days. All I will pay is $1,676. Now, at 60 days, we don't even want to think a bit about how big that hospital bill is. That's going to be your share of it. So phenomenal coverage for inpatient care. But $1,676 is not a small amount, right? And if you have multiple stays, that can really start to add up. And then skilled nursing facility, This is not where you live. This is where you go after you've been in a hospital, but before you can go back to wherever you're living. The first 20 days are covered in full, but then starting on day 21, you have to pay about $209 per day for your stay. So that's your inpatient care. I always say overall, picking up the majority of the bill and no premium, it's fabulous coverage. Now, for the outpatient care, this is part B. There is a premium to be on outpatient care. It's $185 per month for most people. If you're considered highly compensated, you will have to pay more to be on Part B. And Part B only, it won't impact your other policies, but you'll have to pay more for Part B. So you pay $185 a month to the government. And then there is a $257 annual deductible. And everything I'm telling you is for 2025. The numbers will be slightly different next year. And then once the deductible's been satisfied, in general, the government's going to pay 80% of the bill. You'll be responsible for the other 20%. Now, 20% is a pretty low cost sharing for health insurance. Um, However, there is no cap or limit on that 20%. Government's always going to be there paying 80% of the bill, regardless of how many bills there are and how much it adds up to, but they expect you to be coming in and paying the balance due as well without any limit. So that's going to be an area we talk about in a little bit. Great coverage, but you've got some financial exposure. I think all of us are happy to pay our share of the bill, but all of us have a budget and a limit on how much medical exposure we can handle. So we're going to talk about getting help with your share of the bill and how that works. And, okay. I just rearranged my slide deck, so I had to see what was coming next. It's time for questions. So let me take a quick look here at something. Any questions in the room? Anything I can clarify in terms of, yes, so we have a question in the room, and I'm going to repeat it for the online people. Start here. So the hospital deductible is per hospitalization. So it's not an annual deductible, it's a per stay deductible. You could have multiple 1 days. It's per stay. Oh, I'm sorry. I need to repeat the question. Thank you for the reminder. So the question is, under the Part A inpatient care hospitalization, the hospital stay deductible is not for the year. It's per hospital stay. Whether you're in there 1 day, 5 days, or 60 days, you have to pay $1,676. So I break my hip in the spring. I have to go in, stay a few days. I pay $1,676. I'm back out. I'm recovering. I get pneumonia in the fall. I get complications. I'm back in the hospital. I pay $1,676 again because it's a new hospital stay. Okay, we have another question. Okay. Okay, there's a little bit more complicated question. I'm in the hospital, I get discharged, but then I get readmitted the next day. So if you are, this is not a call that I'm going to make as a broker. This is a call that's going to be made by the hospital and the insurance company. But normally, if you're readmitted for the same condition, maybe you shouldn't have been released so early, that should be just a continuation of that stay, is normally how that's treated. But I get out of the hospital, I broke my leg, I get out of the hospital, and then I get hit by a bus. So, and I'm back in the hospital. It's a brand new event. It might start the clock over. So, but if it's what we call a readmission, you might not be charged, but I don't make those calls. Thank you. Insurance companies and provider groups. Yeah, brokers don't make any calls on how coverage. So someone wanted to know who makes these calls on what get paid. Never your insurance broker. We just tell you how it works. And then we've all had bills where sometimes something comes into question or how should that be billed? That might be one of those situations. Sometimes it's very straightforward. Oh yeah, you shouldn't have been released, or this is a continuation of your past illness, and but we don't make those calls. That's the insurance company and the hospital that determine that. Okay. In this case, the insurance company being the government. Okay. Perfect. Any other questions on the A and B benefits, your core coverage? We're good? Nothing online? Okay, fabulous. All right. So what I'm going to talk about now is when do you apply for A and B? So right now we're still just focusing on the government policy because I just can't state it enough. This is the most important policy. This is where all your medical benefits come from. Anybody who is on Medicare has A and B and is paying for A and B. This is what drives the whole system and the whole program. So when do you need to go on to Medicare Part A and B? So we're going to go with the primary default, and then we're going to talk about an exception, a big exception. So the standard line is you're turning 65, you need to apply for Medicare A and B. Because if you don't enroll in Medicare when you're supposed to, if you say, oh, I'm good, I'm healthy, I'll take A because it's free, but I don't want that Part B, I'll get that later, you're going to run into trouble down the road when you go to apply for Part B. The government's going to say it doesn't work that way. You don't get it once you need it. That's not how insurance works. They want you enrolling in Medicare Part B when you turn 65. And if you don't, there can be a big penalty down the road. And again, there's a big exception I'll talk about in a moment that someone online or maybe one of you guys is thinking about. We'll talk about that in a sec. But let's start with you got to enroll in Medicare A and B. This is what it looks like. One sec. You are going to get a 7-month window based on your birth month. So you can see on this timeline, I'm turning 65 and it's sandwiched right in the middle of those 7 months. So in my case, I'm born in October. So, and I'm not on Medicare yet, but when I go on Medicare, my window to enroll in Medicare Part A will open up July 1st, 3 months before the month I was born in. And by the way, Medicare always starts on the first of the month. There's no, I'd like my Medicare to start on October 15th or October 13th. It's always going to start on October 1st or December 1st or whatever. So for me, I'm born in October. If I apply in those first 3 months, July, August, or September, they will have my coverage start on October 1st. And I was not born on October 1st. So it'll start before I'm actually technically 65. If I apply in my birth month in October or in the 5th, 6th, or 7th month, it will start the first of the following month. So if I apply in October, it'll start in November. If I apply in November, it'll start in December and so forth. You want to make sure you get your application in that 7-month window. And for most of us, we're going to do it in those first 3 months. We just get it in. It'll start on the first of our birth month. That's standard. And you do this on the Social Security website. There'll be a enroll in Medicare and you can get signed up. Now, quick exception. If you know anybody who's born on the first of the month, there's this weird rule, a little bit different timeline. I'm born in May. They actually move my timeline up. It starts earlier. They treat me like I was born a month earlier. This is important because if you're born in the 1st of May, you don't have 3 months after May to still enroll. Now you only have 2 months. So make sure you're aware of that. If you're born on the 1st, or if you're at trivia night and it comes up, you're going to score some points for the team. What happens when you're born on the 1st of the month? They treat like you were born the month before. Okay, so that's that's an exception. That's not the big exception I was talking about, but I always like to bring this up because 1 out of 30 people was born on the 1st of the month. So it's important. Now here's the big exception. I'm turning 65, but I'm still working and on employer coverage. Do I need to apply for Medicare A and B? And the answer is probably not. If you're going to keep working, you probably don't need to apply for Medicare A and B. Here's what we advise most people do. So if you are on an employer group health plan, we advise you to go ahead and apply for Medicare Part A only. Doesn't cost anything, right? And then what we're going to do is we're going to hold off on applying for Part B because guess what? Being on a group employer plan is considered an acceptable substitute for Medicare. Okay, so again, I'm on an employer group health plan. Government's fine with that. They're like, that's okay. You don't have to get Medicare yet then. So I'm going to apply for A only. And then whenever I'm ready to retire, that's when I'm going to apply for Part B. And again, it's that 3-month rule. Get your application in 3 months prior to your requested start date because it takes the government a while to process the government coverage. Along with that, you're going to have your employer fill out what's called an employer verification form. It's a form from Medicare where they're just going to document and say, yes, they really had employer coverage. So that's your proof that yes, it was okay. You did not apply for Part B back when you were 65. So that's what you're going to do. Apply for Part A only. And then 3 months prior to when you're ready to retire, then you're going to apply for Part B. And you're going to get that employer verification form. Now, big exception, and actually there's a second exception I'm going to throw out there. Um, the big exception is if your employer plan is an HSA plan where you're contributing pre-tax dollars. If it's specifically a health savings account, HSA plan that you're contributing pre-tax dollars, do not enroll in Part A because you won't be able to contribute that money into that account. Okay. And if you guys don't know, if no one knows what I'm talking about, that's fine. It means you're not on that kind of a plan. But if you are on an HSA plan, don't apply for Part A. Also, I really want to clarify being on an employer plan. An employer plan is not COBRA. It's not a retirement plan. It's not company paid COBRA. You have to be an employee who is on the active list as employed. Okay. The other thing is this just came up today, and we're looking into it. You you have a window to enroll in Medicare A and B. And so sometimes people will rely on COBRA to cover them while they get their Medicare set up in that 7 month window. Again, COBRA is not a suitable exception, but maybe I'm in my 7 month window. I'm running tight on time. I might have to go on COBRA for a month or two. We are hearing now that some companies or COBRA won't cover you because they want Medicare to be primary. So just exercise caution with that. Okay. And if you're on a smaller group plan, less than 20 people, same thing, check first, make sure it's okay for you to just be on that employer plan and not have Medicare A and B. So this is where it gets a little confusing. So small group plan, less than 20 employees, double check and make sure that employer plan will pay as primary because they don't have to be primary. It's when they're 20 employees or larger that they have to be primary. So make sure they're going to cover you. And then if you have to use COBRA for a few months to cover as you're getting your Medicare in place, double check and make sure that COBRA will cover you as primary. Okay. Hopefully nobody will have those scenarios. Okay. Any questions on when to? It was all sounding really good until we got to this page and the exceptions, right? Yeah, so just exercise caution. Any questions on applying for Medicare A and B, when to do it? You're good? You're good? Yeah. So great question. So the question is, what if you're already over the age 65? You've not applied for A and B, but you are on employer coverage. So you're covered by a 20 or more person group plan. Yeah. So you're fine. You don't need to be on A or B. The nice thing about A is there's no penalty. It doesn't cost anything to be on it. So the government's like, great, if you don't want our free coverage, that's fine. At any time, you can come back to them and say, you know what, I do want to go on Part A. I normally recommend, as long as you're not on an HSA plan, put the Part A in place. Number one, it's some secondary extra coverage just in case you have inpatient care. Your employer group will be primary, but that Part A might come in and help pick up some of your share of the inpatient care. But number two, it actually makes the process a little bit easier down the road when you go to apply for Medicare Part B because you'll already have your Medicare number in place. And it makes it a little bit cleaner in terms of making that transition. Yeah. Yep, absolutely. Yeah. So with the eight, no, what I'm saying is if your employer health plan, that's your primary coverage, end, and your employer plan is an HSA plan, a high deductible health savings account plan, I don't, it's not compatible to be on an HSA employer plan and have Part A. The rules are you're not supposed to do that. More specifically, my understanding, but I would check with, if you are eligible for an HSA, I would check with your benefit department. My understanding is you actually can be on the HSA plan, but now you can't contribute any money into that fund. And that's one of the big benefits of having an HSA plan, right? So it's like, well, you can be on the plan, but you can't put any money into it. Okay. All right. Perfect. Should we soldier on? Okay, that was fun. No, good questions. Good questions. And like I said, there's a reason I've been doing this for 15 years. It's confusing. Parts of it are. All right. So next up, what have I got next up? Oh, the key points. Like I said, I've got my slides rearranged. Okay, so when you enroll in Medicare Part A and B, what I want to stress is you put all your health insurance in place. All your medical benefits are now taken care of. We can check it off the list. We don't moving forward, anything we talk about, we don't have to worry about. Will I be covered if I'm hospitalized? Will I be able to get knee surgery? Can I go see my primary care? We've just locked it all in by applying for Medicare Part A and B. That's your core coverage, and that's where all your medical benefits come from. And you're going to keep that policy in place, and you're going to pay the government directly from now until the end to be on that policy, unless you go back to work. Okay. What we're going to focus on now is how to get help with your share of the medical bills, how to get help with the cost of prescription drugs. And then we can touch a little bit on non-Medicare benefits. They're not included in A and B, but they can be very important and in some cases can be kind of pricey, like dental care and vision and hearing aids and alternative care. So that's what we're going to focus on now. But I really want to put a pin in it that, we've set up your medical coverage by having you enroll in A and B. And now we're just adding coverage to it to kind of fill in some spots where maybe you want a little bit more help. Okay, perfect. So here is, I think, the Medicare map. There it is. Okay, so we've got the A and B at the top. We've got that in place. And now we're going to add coverage. And so, especially in the fall, you turn on the TV, you listen to the radio, you open up the newspaper. It's all over the place. There are so many plans and so many companies, right? And they all are like, buy my stuff. It's the best. You have two options. Okay. You are either going to add a Medigap plan with a Medicare Part D drug plan, or you're going to add a Medicare Advantage plan. Either one of these options, one or two, is going to get you help with your share of the medical bills and help with the cost of prescription drugs. Those are the two biggies that we work on for people. Okay. It's kind of like saying, here's the deal. There's only two types of cars that have ever been developed: trucks and minivans. What do you want to get? We immediately know that they have an awful lot in common, right? They all have brakes and steering wheels and engines and the whole bit, but we're going to have a preference. Like, I had a minivan. I loved it, but I like trucks too. But you're going to settle on what's right for me. It's the same with these plans. So all the Medicare Advantage plans all kind of work the same, and all the Medigap plans all kind of work the same. So we're going to take a look at how these plans work and kind of give you those key points on which approach you like better. This is a starting point. It's not about diving deep into the details of every single plan. It's about understanding in general how they work first. Then you can get into the details because you'll know what you're looking for. Okay. So let's start with option one, Medigap plans. So these plans are so simple, they're confusing. You were like, wait, what? How does this work? So everything we're talking about now comes from private insurance companies, but all of these companies and plans are highly regulated by the government. They have to go through an approval process. Okay, so there's still a ton of oversight on them. So comes from a private insurance company, and it's a really, really simple premise. They want you to pay them a monthly premium whenever, every month you write them a check. And then in return, they're going to pay some or all of your share of the medical bills. You're going to shift that uncertainty of, I'm sorry, it's like I had my back to you the whole time. I'll come over here now. I'll look at you for a while. Yeah. So what they're going to do is you're going to pay them a monthly premium. And then when you need medical care, they're going to come in and pay some or all of your share of the medical bills. And the hallmark of these plans are I had knee surgery, I didn't pay anything. The people who say I had all this care and I didn't need anything, it either means they're on Medicaid and fully covered by the government, or they're on a Medigap plan. Okay. So they're going to help pay some or all of your share of the medical bills. There's no provider network because they're not a health insurance company. They're strictly a check writing service, is what I say. In essence, they're waiting for the bill to come in. Government's approved and paid their share. They're going to pay the balance due. There's no provider networks then. A doctor will happily cash a check from whoever wants to write a check for what you owe. So you can go to any doctor anywhere in the country that accepts original Medicare, and the vast majority of doctors do, and virtually all hospitals. Um, it does not provide any additional benefits. So you're not going to get any dental or routine vision or hearing aids or any of that good stuff. So it's really just about helping you with your share of the bills. Pay a fairly large premium up front, pay little to nothing when you actually need medical care. And it works hand in hand with your original Medicare policy. Make sense? So these are the Plan Gs, the Plan Ns, the Plan Fs that you may have heard of. So they're standardized. So what you pay does matter on these plans. Paying more with a company for the exact same policy, a standardized policy, Plan G, isn't giving you more. It's just making you pay more. So we look at there's probably 20 companies out there that sell these supplements, and they're all selling the same thing, just like a car dealership. So you don't have to overpay. You're looking for a competitive price point, but you're also looking for a company that's kind of been stable in the marketplace, that year after year they're competitively priced and they do a good job. Questions on the Medicare supplement policies? Right. So the question is when the bill gets submitted to the Medigap company, is the Medigap company going to push back? Like we hear about with insurance, like, hey, we don't think you needed that surgery or something wasn't right about the billing. The answer is no, they're not allowed to do that. It's a financial contract. The government's the insurance company. They're the one who gets the bill, looks at it and says, yeah, everything's in order. We need to pay for this knee surgery. The government pays their share of the bill, and then it sends the balance due to the Medigap plan and says, here's what Gene owes. Write him a check. They have absolutely no say in the matter. If it's approved by Medicare, they must pay the balance due or whatever the contract says. So they're very trouble-free policies. I don't hear from these clients ever, at least on that. Yeah. So very, very trouble-free. Yes. So there's So the question, are Medigap policies the same thing as Part B supplemental? There's actually technically not a Part B supplemental. Um, Medigap plans are also called Medicare supplement plans. And so what they are is they're just a completely separate policy that's designed to come in and help pay some or all of both your Part B and your Part A costs. I hear a lot of things that there is no Part B supplement. Yeah. So I hear a lot of terminology that is not actual terminology, but it's understandable that it happens because there's a lot of terms that fly around. So this is a Medigap plan, also known as a Medicare supplement policy. Okay. Question. Yeah, so the Medigap plan, so we'll start with the policies. They're standardized policies. So I think there are, depending on how you count it, there's 10 standardized policies. Most companies don't sell a lot of them. The most common ones that all the companies sell are the Plan G and the Plan N. And so if someone were to say, Gene, can you send me over some Plan G and Plan N policies, I would send them, here's a Plan G, here's a Plan N. They're like, there's no company name on it. It's like, that's right, because it doesn't matter if you get it from the Smith Company or the Jones Company or the Acme Company. If it's a Plan G, this is what the policy will do, period. So there's not as much shopping as you would think. The first thing is like, which do I prefer? And then you can go out, you can go to the state of Washington website. The Office of the Insurance Commissioner every quarter updates what's the pricing for all the companies that are offering G's and N. Yeah. So then you can see the pricing. Yeah. You don't have to do it. And then from there, as a broker, I don't represent all of them. I've selected companies which they've got a good, I'm always looking at what are they charging now, but what are they charged historically? Are they what we would call rate stable? We always have new companies coming in who come in below the market and they'll hold their price down for a year or two or three, and then they start taking big price increases and hopefully settle in the midpoint with everybody, but sometimes go shooting past. Um, so we look at those types of things. So I would say you're safe with someone in the middle of the market. If you want to go with someone who's less expensive, on the low end, understand they might start to play catch up a little bit faster or take rates increases a little bit more quickly. But with all of them, they work well. They're very simple. There's not a lot that can go wrong with them. They're very trouble free from a customer service standpoint. Yeah. Oh, the if you just search Washington State Medigap plans and look for a Washington.gov site to come up, Office of the Insurance Commissioner, there's a PDF that comes out every quarter with the updated rates. Absolutely. And I realize I don't know if for the person who's online, did I repeat that question? Or they're good? Okay, I'm sorry. I keep giving you. I need to be better at repeating. Okay. Any other questions on the Medigap plans? Oh, I'll throw in one thing real quickly. Nobody's asked about it, but international coverage, Medicare doesn't, A and B does not work outside of the United States. There's these really weird exceptions. Don't count on them. Um, the Plan G and the Plan N and one or two other plans do build in all of, if you're on a Plan G, it will have an international travel benefit built in. It's a very basic emergency only. There's no follow-up care. This is strictly, we're going to keep you alive. But once you're stabilized, get back to the United States. Okay, those are US territories. So those you should be able to receive Medicare care there. Yeah. Oh, repeat. I'm sorry. Someone asked, does that include Puerto Rico and Guam? And the answer is yes, those are US territories. So Medicare works anywhere in the US where they're territories. Question. Yeah, correct. So yeah, you're no, so outside the country, your core medical coverage A and B does not work. I go up to Vancouver, BC with my friend and we decide to go zip lining and I do something and I wind up in ER. Medicare A and B is going to do nothing for me. It's like drag me across the border and get me back. So again, not all supplement types. Again, these are the letter plans, the G's, the N's, the F's. There's some others in there, K's and L's. Not all of them include an international emergency benefit, but the G and the N do. So now it means I can go to Canada to visit my friends, and it's like, oh yeah, good. I've got that in my back pocket. All right. So we get the Medigap plan to help with our share of the bill, right? We're going to pay them a monthly premium. I'd say on average, most people are paying, depending on their circumstances, on the low end, maybe 140, 150 a month, as much as 260 a month to have one of these policies. But you have very minimal out-of-pocket costs. So you're kind of shifting that uncertainty of what if, how much could this possibly add up to just have to write this check every month on top of what you're paying for A and B. Yes. We'll say for now 140 to 260 a month, I think would be a good range to deal with, depending on the policy type and the company you go with, who you decide you want to work with. Okay. We'll talk about when you add coverage. Yeah. So no, you actually can't. I'll state that right up front. If you want to go on a Medigap plan, you're going to want to make sure that you get that in place at the time Medicare becomes your primary coverage. When you turn 65 or when you retire at age 68 or whenever, you're going to sign up, get your A and B in place, and get your Medigap plan set up. Because if you don't get a Medigap plan, when Medicare becomes your primary coverage, you can always go and apply to them any time of the year, say, hey, I think I want your coverage now. But they don't have to grant you coverage. They're going to run you through health underwriting questions. And in the state of Washington, it's either yes, we'll give you a policy or no, thank you. We don't want to do business with you. So it's not a guarantee. Once they time it off of 6 months after your Part B starts or when you leave employer coverage. Those are your two windows to get on it, usually without health underwriting. Okay. Perfect. Good questions. And we're still, yeah, no, we're good. We're going to make it. Checking the time. Okay. Part D drug plan. So again, the government coverage is going to help for those drugs that I'm receiving as an inpatient. It's also going to help if I'm going in for outpatient drugs like chemotherapy, certain injections, things of that nature. But for the stuff that's at home in my medicine cabinet, including injectables and topicals and other things, Medicare A and B does not help with the cost of those. So in this particular scenario, you're going to go ahead and enroll in a Part D drug plan. And it's the same concept as your employer coverage now, right? You go to the pharmacy, you give them your insurance card, they look it up, they say, oh, this is your deductible, this is your co-payment. You grab your drugs, you go home. Same thing is happening here. The difference is this plan might come with a premium. So we do have some zero premium plans. We have plans that are as expensive as up to like $110 a month. So there's 12 plans. What's nice is you can shop the plans. You can just plug in your drugs and it runs it. And it's checking to make sure that their list of covered drugs matches well with the drugs you're currently taking. Because some of us have had that experience is our employer changes our drug plan or our insurance plan. And you go to fill your drug, it's like, oh, the new insurance plan doesn't cover this drug. Talk to your doctor, make a switch. Okay, nobody's had that experience. Somebody has. Okay, that can happen. So what's nice is you can actually pre-shop the plan and make sure it lines up with where you're at right now. But all of these plans must provide drugs to address everything that ails us. They just don't cover every drug that's out there. So we just want to line you up with a plan that matches up well to start with and also likes the pharmacy you like to go to. Maybe you really, really like, I don't know, Walgreens. You want to, it'll help match you up with plans where Walgreens is a preferred pharmacy and works well. Pardon? Or I know Bartell's, yeah, our local hometown pharmacy. Um, so the government provides very strict guidelines in terms of how this has to work. They want to make sure that you're well covered. Now, for those of you who don't take any prescriptions, it can be tempting to say, well, I don't need this right now. But remember, insurance is not about, well, I don't need it now. I'll just start paying for it when I do need it. Guess what? If you don't get it now, you can get it later, but you're going to pay a permanent penalty for all the time you went without coverage. That would be like forever. You're going to pay more for Part D drugs based on the time you went without coverage. Not to mention, you might go to a period of time being able to get on the plan. You can only get onto it in the fall. So you might be waiting. I've had people waiting up to 8 months to get on these. And in the meantime, paying out big money for drugs. So please do yourself a favor, enroll in a Part D drug plan. If you don't take any drug plans, that's why we have those zero premium plans out there. Okay, great. So that's option number one, getting a, oh, I'll go back to the chart. Okay, we just did option number one. That's that Medigap plan with a Medicare Part D drug plan. Just want to give you a visual reference. Okay, now we're going to talk about the Medicare Advantage plans. These are the ones that advertise like crazy. So what's happening with a Medicare Advantage plan, they'll say the Medicare Advantage plan, they literally say this, I don't agree with it. They say Medicare Advantage replaces your Medicare Part A and B and gives you a drug plan and may give you some other benefits. It does not replace your Medicare A and B. You still have to have Medicare Part A and B. This is going to be an addition, but what's going to happen is a Medicare Advantage plan is a private health insurance company. Now we're back to it's a health insurance company that has a contract with the government to manage and administer your A and B benefits. The government is outsourcing the whole, where do the bills go for review? They're no longer going to go to the government, and the government's no longer going to directly pay their share of the bill. Instead, now the medical bills are going to the Medicare Advantage plan. The Medicare Advantage plan contractually is required to make sure you have all your A and B benefits and to pay the government share of the bill. Their 80%, their share of the hospital bill. Okay, got that? They're a government contractor. They're just stepping in and doing the government's work. So the government's going to give them a big check every month. And then in return, whenever you need medical bills, it goes to the Advantage plan. They pay out the government's share. You're responsible for the balance due. We'll keep going. Bear with me. Oh, let me get through this and then we'll circle back. So I continue to pay the government my Part B benefit. The government then sends a check over to the Advantage plan. The Advantage plan is going to pay the government share of the bills on behalf of the government. That's what they're getting paid to do. You may also have to pay a premium to the Advantage plan. Now, Advantage plans tend to be much less expensive, but there can be premiums. Most people are paying between zero and maybe at the high end $100. A lot of people are down around zero, $30 a month to have these policies. So you pay the government, then you pay the Advantage plan. And now when you need medical care, the Advantage plan is going to pay the government share of the bill, right? Just like A and B would do. The balance due, it's back to me having to pay it. So I have to pay my 20% of the bill. When I need outpatient care, I have to pay that hospital portion when I need inpatient care. But the Medicare Advantage plan is going to set a limit on how long I have to keep paying out. Remember when we first talked about original Medicare? It's like you always have to pay the balance due. And everybody's like, how much could that be? It could be a lot. The Medicare Advantage plan says you have to pay the balance due, but we'll set an annual limit. So a common annual limit on these kind of plans, now we're down at maybe $0 a month. I need to make co-payments when I need care, but maybe they'll limit how much I have to pay out to only $6,500 or $6,700. That would be a worst case scenario, not a deductible, a worst case scenario. So it's more of a pay as you go. Keep the money in your pocket, pay your share of the bill when you need care, but know that there's a limit beyond which you no longer have to pay the bill. So that's how the Medicare Advantage plans are set up. And then most plans include Part D drug coverage in the policy, including the zero premium plans. Now, the plans that do not include Part D policy are not meant for people who don't take drugs. They're meant for people who have drug coverage through another source, normally the VA benefits, or TRICARE. Okay, so please do yourself a favor. Even if you don't take drugs, don't look at those plans without drug coverage. Make sure you look at a plan with drug coverage unless you have VA benefits. So I pay my monthly premium, might be zero, might be $30. I make my co-payments when I need to. And so now that this is all running through this private insurance company, the rules change a little bit. I can no longer go to any doctor anywhere in the country that accepts original Medicare. These Medicare Advantage plans are going to come with a network of doctors and hospitals, just like your employer plan has, and most medical insurance under the age of 65 has, right? This is where you can receive care. So it's important before you run out and start, comparing all the different Medicare Advantage plans, start with which ones are my doctors in network with, not which ones do my doctors take. That's different. Doctors will bill anybody, but you want to make sure they're in network. Now, with these plans, the networks can be quite large. We have some really huge networks that really include all the major provider groups, I can say that, in the Puget Sound area. So you could have your primary care at University of Washington, but a specialist at Swedish and a different specialist at Virginia Mason. You might, really kind of hop around depending on the specialist. So you can have a lot of choice with some of these Medicare Advantage plans, but it is a network. And it's important if it's an HMO network or a PPO network. A PPO network means this is our network. This is where you get your best price. If you want to go out of network, you can, but it's going to cost you more. You're going to pay more to go out of network, and it's usually not cost effective to do that. An HMO plan says this is our network, and HMO plans can have a really big network, but the HMO part means you can't go out of network. If you do, they won't pay for your care. So you're now committing to, I'm going to work with the provider network that you're giving me, and I'll just stay within that network. So you'll want to be aware of that if you're looking at Medicare Advantage plans. And then these are the plans that can provide additional non-Medicare benefits, and they really like to try to play these up. I always laugh. It's like, we're going to give you your dental and vision and hearing aids and a free puppy and, it's just like whatever they can do to get you in the door. Um, some of these benefits can be nice, but this is really important to know. We're definitely having a shift in the Medicare marketplace right now. We're getting a lot of cost constraints on the system and on the care, insurance carriers. They're starting to really scale back on these non-Medicare benefits. Because remember, as a government contractor, they have to provide you with all those medical benefits. They can't mess around with your medical benefits and they can't mess around with those cost sharing rules. They can't start making you pay 30 or 40 or 50% of the bill, right? So they're obligated to follow the government's guidelines. These extra things like the dental and the routine vision and the hearing aids, this is all extra stuff they built in. This is the stuff from year to year that can change. So just be aware of that because a lot of us, we retire, we're used to our great employee plan and then that great dental plan they give us too, right? And now we're launching off on our own. It's like, holy crow, I've got bad teeth. What am I going to do? Um, the Advantage plans can be great. They can have really generous allowances, but they're not a dental policy. And the next year they could say, yeah, we're not doing that dental allowance thing anymore. So keep that in mind. You can purchase individual dental insurance policies from companies like Delta Dental, and there's others out there. For routine vision, you can spend as little as or as much as you want on eyeglasses. This is totally off topic, but I'm a big fan of Costco because I'm cheap and it works for me. And I'm like, it's a bargain. It's a bargain. You can find bargains on glasses, so you don't necessarily need a VSP plan, but you could look at that. So there's ways to do it. So I think my word of advice on the Advantage plan is these extra benefits can be nice, but recognize them for what they are. This is like a this year only attitude. Like this isn't your long-term plan necessarily on how you're going to cover those costs. Okay. So those are the Advantage plans. Any questions on the Advantage plans? Did I clear up that whole how they're connected or should we keep going? We have a question. Oh, here. Well, like she beat you to the punch. Okay, yes. Advantage to Medigap, not necessarily possible. You're just ahead by 3 slides. So good. You're setting it up for me. We're getting there. Any other questions on the plans themselves? Oh, and the question was being able to switch. Oh, 3, 4 minutes left. Yeah, okay. Um, okay. Let's do this. Let's keep going and then I'll stick around. But yeah, let's get through the content by 5 o'clock or thereabouts. We started a couple minutes late. All right. So here's a quick side by side. So I always say, really, the first thing is to decide what am I more comfortable with, right? Which plan appeals to me more? And they both have something to like. Um, down the center are kind of like, what are we talking about? The A and B benefits, we know those are the same. So we're taking that off the table. Although clients will say, are you sure it covers knee surgery? Yes, they all do. Next, the premiums and the out-of-pocket costs. The Medigap plans, we're going to have a pretty high premium, but pretty low out-of-pocket costs when we need care. The Medicare Advantage plans, it's the opposite. We've got a low premium, but then when we need care, the more care we need, the more cost we have. Now, what we all want is we want a low premium, low out of pocket cost plan, but that's not the way it works. You got to kind of balance that. Do I pay more in premium, less in out of pocket, like any insurance? Okay, so that's the first difference. The next has to do with networks. Again, we have some really strong networks here in the Puget Sound area, but it still does add a layer. And in recent years, the network contract negotiations have become a little bit more contentious, which is kind of concerning when your carrier is saying, I don't know, we might, or your provider, Swedish, is saying, I don't know, we might kick, the Acme company out of the network. It's like, but that's the company I'm on. So networks, they work, they're large, but they're not for everybody. So if you don't like networks, you go on Medigap plan. If you're comfortable with networks, the Advantage plan would be fine. Drug coverage in terms of what you actually pay for your prescriptions, your actual out of pocket is going to look really similar, but you will have that added possible premium on the Medigap plan side. And then those non-Medicare benefits, there's no extra bells or whistles on the Medigap plans. We do have them on the Advantage plans, but again, with a big disclaimer that it's a 1 year only, and we'll see what they do the next year with those. So those are some things to think about when you're making plan comparisons. And here's just a quick Mary Medigap and Michael MAPD. My assistant came up with that. I'm like, that works. So Mary Medigap, she got a Medigap plan because she loves the idea of lower out-of-pocket medical bills. She'd rather just pay it up front, set it and forget it, not worry about what's going to happen. She doesn't want to deal with a network and having to double check is this doctor and network. And she's fine paying out of pocket for that extra stuff that's not covered by Medicare. Michael, Medicare Advantage plan, he loves the idea of I want to keep the money in my pocket. I don't want to give it to the insurance company up front. I'm happy to make my co-payments whenever I need medical care, as long as I know there's a limit to my exposure. Comfortable with the provider network. Some people will be like, as long as I can go to the University of Washington, I'm good. And that's fine. And then he likes the additional non-Medicare benefits that can be included with the plans. He's like, hey, I'll take whatever extra goodies they'll give me. So things to consider. Okay, 2 more slides. When can you change coverage? And the next one will be what coverage can you change? So when can you change coverage? So this is after you've gotten set up, right? So I apply for Medicare A and B 3 months prior to when I need it. I get that application in, and while I'm waiting for that to process, now I'm comparing what policies I want to set up. That's your initial enrollment. But now I'm set up on whatever. I can make changes during annual enrollment, October 15th through December 7th. This is normally for your Medicare Advantage plans and Part D drug plans. I can make changes to my Medicare Advantage plan during the whole first quarter of the year as well. A lot of people don't know about that. It's called open enrollment. Best to do it in an annual enrollment, but this is kind of your do-over period in the first quarter. There are special enrollment periods because sometimes things happen mid-year, like I move out of the area and my plan isn't where I'm moving to. So you'll have special enrollment periods when you can make changes. And then Medigap plans are open enrollment year round. So at any time you can change your Medigap plan or apply for a Medigap plan, but as we just found out, you might have to go through underwriting. So let's talk about what you can change. All right. So MAPD is a Medicare Advantage plan. So MAPD to MAPD, yes, we can make that change in one of those time periods. PDP is a drug plan. I just realized I need to change what I put on these slides. Don't make sense to you guys. PDP to PDP, that's a drug plan to a drug plan. Yes, no problem there. We do it in the fall, no restrictions. Medigap to Medigap in the state of Washington any time of the year. So if you're on a Medigap plan, at any time you can say, I don't want to be on a G anymore, I want an N. Or I want to keep my G, but I want to change from the Smith Company to the Jones Company. You can do that at any time in Washington. Different rules in different states, so don't get in an argument with your cousin in Kansas about the rules, because it's probably different there. Okay, Medigap plan to a Medicare Advantage plan, no problem. Okay, it's this last one. I'm on a Medicare Advantage plan, and now I want to move to a Medigap plan. I love paying zero and not having any co-payments, but now I'm really sick. I'd rather pay a bunch of money up front and just not have those co-payments. That's probably not going to happen. They're going to ask you health underwriting questions when you make this move. In most cases, there's a few exceptions, but we'll operate under, if I start with a Medicare Advantage plan, not guaranteed to get a Medigap in the future. Okay. Whew. Okay. Wrapping it up. Resources. Social Security is where we go to apply for Medicare Part A and B and just check on eligibility. You can also apply for additional help. So for people who have limited incomes, there are resources available. Medicare.gov, I always say if you have questions about, to go into the website is just totally overwhelming. But if you go online and Google a very specific question, look for the Medicare.gov or CMS website response, and they really deliver good information. There is a Medicare and You handbook that you can download, and it's searchable. So a lot of people will be like, is physical therapy covered? It's like, whoop, pops up. Yes, it is. So it's a great reference guide. Oh, so yes, they have the Medicare and You handbooks at branches and they're in 4 different languages. So it's a great resource, as always, your library. At the Central Library also. Perfect. Okay, so there's that information. And then last, here's my information. If you have any questions, you're welcome to reach out because I know I just shoved a lot of information at you, but you have your handouts as well. And a lot of what's in the presentation is in there also, at least the key points. Awesome. Okay, that's it for me.